webinar in the MITRA group, and it's been a great job done by Saujanya in initiating this. And I know that how much of tremendous work would have been gone behind to have this 101st webinar. And I'm happy to be a part of MITRA group. Saujanya, thank you so much for making me a part of it in terms of creating awareness in the ways possible for us. Yeah, so today's topic, probably as mentioned, that most of you would probably connect with this because most of the children with autism, at some point of time, they are picky eaters. But what you need to understand, or what is important in this particular webinar is, we are going to discuss about the most neglected topic, or where there is not much of interest being laid in that particular area, but a lot of research has been taken place in terms of this particular topic, especially autism and nutrition. Autism and nutrition, they go very hand in hand, because all of us know that our children have got a lot of defensiveness, or they are picky eaters, and there are a lot of compromise in terms of their nutritional capabilities, or the body's absorption of nutrients as such. So today we will discuss more to do with picky eating, and later on, probably in the followed webinars, we'll talk about food intolerance and food allergies, and different specific diets meant for children with autism, and the impact of all that. But today we'll try to focus upon picky eating as such. There are two components what you need to understand. Most of the time, people call it as picky eating, and that's a term which is widely used. But what you need to know is there is a difference between two terms. One is called as picky eaters, and another one is called as problem feeders. And most of the children with autism are problem feeders rather than picky eaters. So I'll probably differentiate that to you in going ahead. And most of the parents, most parents of autistic children are concerned about what they perceive as their children's pickiness about food and negative mealtime behaviors, right? A lot of children will have negative mealtime behaviors. So there is three different components embedded in this from three different perspectives. One perspective is from behavioral component of it. The second perspective is from speech pathologist, speech language pathologist perspective. And the third component is an occupational therapy and sensory integration perspective. And what you need to remember before actually going on into the topic, it is a teamwork. It's a teamwork of these three therapists together, working on different areas, because most of the time it is a combination of all these three concerns, all these three areas of concerns which play a vital role in terms of getting our children to eat. So whenever you talk about feeding therapy, it is more to do with a team of an occupational therapist, a speech language pathologist, and ABA therapist, along with the primary care physician of the child or the pediatrician of the child. Now, our children tend to have poor appetite, prefer to drink rather than eat, right? And they refuse new foods. They accept a very limited variety of foods, and crave for a lot of carbohydrates, and have need for the sameness and the routine around the rituals and routines around eating. For many families, mealtime is considered as a battleground, right? Where child gags, vomits, throws food, have got a lot of temper tantrums, and they refuse to eat. As parents, probably you would have tried everything from force feeding, bribing them, or pleading to distract using mobile phones or televisions, or bites of food throughout the day, right? You keep giving bribing a child throughout the day, and but usually none of these techniques most of the time doesn't work, and parents are left feeling overwhelmed, and sometimes it causes a lot of depression, right? When your kid doesn't eat, or when you're trying to get them to eat whatever they can and they refuse to eat, that causes a huge amount of you feel defeated most of the time, right? And that causes too much of concern, which causes a lot of concern, right? Unfortunately, many healthcare practitioners don't understand problem. and the negative mealtime behaviors, and they are unable to help parents resolve them, which only adds to your frustrations, right? So parents are often misinformed or told not to worry, and your child will outgrow picky eating stage, or he will eat when he gets hungry enough, right? They most of them say that wait until child becomes hungry and then you can feed him, and probably they overcome this picky eating. But this is not true for kids with feeding problems, and most autistic children do have feeding problems as opposed to simply being picky eaters. Now, there are two things which you need to remember. In order to help your child overcome issues with food, you first need to determine whether he is a picky eater or a problem feeder. That these two terms are two different things. So most of the time, as I said, problem feeders are considered as picky eaters, but these two are completely different, because characteristics of a picky eater child, uh, you know 50% during the child development, picky eating is considered to be normal, especially between 18 to 23 months of development. That's a point where children try to become picky eaters, and it is a normal development. Please understand that it is a normal development precisely during this time. And the other characteristics of picky eater kids are they eat fewer than 30 foods, and eat at least one food from almost every type of food textures, and eat same favorite food every day, and they tolerate new food and are willing to touch or taste new food, whereas in problem feeders you will not find it, and willing to eat new food after they have been exposed to that kind of food, at least for if you have exposed them for 10 times, they'll start becoming adapted to it, and they'll start eating it. And it is divided into four different categories. It is divided into four different categories, and these categories are, they call it as sensory dependent eaters. Please make it pen it down so that it becomes easy for you when you approach your therapist, and when you talk to them, or when they are talking to you. These terms play a very vital role. So please pen it down. The first category is sensory dependent eaters, who reject food because it's mushy, or it's slippery, or it's bitty, it's bitter, or it is lumpy. The sensory processing concerns, and they are called as sensory dependent eaters. And the next one is behavioral responders. They're called as behavioral responders, who cringe or gag when food is not prepared in the right way, or refuse to come to the table at mealtime. They are called behavioral responders. And then comes preferential eaters, who won't try new foods and avoid foods that are mixed or have complex ingredients to it. They are called preferential eaters. And the fourth one is general perfectionists. Fourth one is general perfectionists, who have very specific needs, little variety, and they have only little varieties in their diet. So they are called as general perfectionists. So the four categories: sensory responders, behavioral sensory dependent eaters, behavioral responders, preferential eaters, and general perfectionists. So these are the four categories which come under the picky eating children. And then comes the characteristics of preferential problem feeders. Now we'll discuss about the characteristics of problem feeders. Problem feeding is not a part of normal childhood development, okay? And it is much more complicated than picky eating, actually. And problem feeders tend to eat a very poor diet, may consume inadequate amount of calories and proteins, and their problems may be severe enough to interfere with normal weight gain and growth. And problem feeders, the characteristics of these children would be they eat fewer than 20 foods and eat fewer foods over time until they accept only 5 to 10 foods, and refuse to eat food from entire categories of textures. Like they refuse to even touch different kinds of textures when presented to them, and they will eat same favorite food every day. So I have seen many children under my experience, where they are being adapted to either one kind of food for last 4 years or 5 years too, and that becomes a huge concern for parents. And when you present these children with new food or new textured food or new color food, they throw different kinds of temper tantrums, which becomes very difficult to handle them, and they won't tolerate new food on the plate, and unwilling to touch or taste new food, and cry or throw tantrums when offered new food, and have a need for sameness and rituals, and inflexible about particular foods. They're like, if I have to give example, if they have to if they like, let's say, if they like chips from if they like potato chips from McDonald's, if you buy from a different store, they will not accept it. The chip might be the same, but they will not accept. They become so inflexible that that particular thing has to be picked up from that particular store only, and they're unwilling to eat new food after 10 typical exposures also. So that is the difference between picky eaters and the problem feeders. So now if you really correlate, most of our kids are not picky eaters, they're actually problem feeders. And causes for feeding problems is very important for you to understand, because once you determine whether your child is a picky eater or a problem feeder, the next step is to figure out why they are picky eaters or why they are problem feeders. The effective way to treat feeding problems is to identify every single contributing factor to that problem, and there are many possible causes or combination of causes. Please understand, this is very important. The first step is for you to identify whether your child is a picky eater or a problem feeder, because the complete management changes for a child with picky eater or for a child with problem feeder. And the causes behind that, as I said, could be only one cause or could be a combination of different causes. And the first one which comes into that is medical conditions. And most of the time, this is something which is grossly missed out by parents or grossly missed out by practitioners. We'll see what medical conditions come under it, but first let me list out what are the different kinds of causes which can come in terms of your child being a picky eater. The first one, as I said, is medical condition. Then second one, the nutritional problems. Third one, retained primitive reflexes. Then oromotor dysfunction, sensory integration problems, then environmental factors and behavioral concerns. I'll list it down again because it becomes important for you to really rule out one by one to see, actually to determine what kind of program you need to actually implement for a child to overcome this problem feeding or to overcome the picky eating. So I'll repeat them: medical conditions, retained primitive reflexes, oromotor dysfunctions, sensory integration difficulties, then you have behavioral concerns, then environmental factors, then nutritional deficiencies. So these are different factors which can cause, or the combination of all these factors can cause or make your child a problem feeder. And most importantly, when you talk about medical conditions, most of you would have heard about everything to deal with gastrointestinal problems, such as gastroesophageal reflux disease. Number one, where you find that where acid in the stomach backs up into esophagus and it becomes inflamed, resulting in a burning sensation in the chest, and that associated with that feeding becomes a physical pain for a child. So if a child is really suffering with gastroesophageal reflux disease, please understand that that is the cause why your kid is not eating. So that is something which needs to be ruled out. And the next one is eosinophilic gastrointestinal disease or disorders is what it is called as. Basically, I hope most of you know about the Nemichek protocol, right? And Nemichek protocol is precisely based upon these eosinophilic gastrointestinal disorders, where it is more to do with the increased number of eosinophils, like the white blood cells, one of the component in the white blood cells, that increased number of that count in different parts of the intestine. It could be in the esophagus, where it is called as eosinophilic esophagitis, or if it is in the stomach or small intestine, it is called as eosinophilic gastroenteritis, and if it is in the colon, it is called as colonitis. Wherein The theory is very simple, wherein the bacterial overgrowth in that particular intestine will cause certain kind of inflammation, and this bacteria will travel through gut-brain barrier and will inflame the cells in the brain, thereby causing the neurotransmission, thereby disturbing the neurotransmission in the brain altogether. And most of the times, most of the children, what I have found out is they do suffer with this eosinophilic gastrointestinal diseases, and it is most of the time being misdiagnosed with inflammatory bowel disease or irritable bowel syndrome or celiac diseases or food allergies. Most of the time it has been misdiagnosed. So please understand that to get it ruled out, it is very important for your child to go through the evaluation to rule out this eosinophilic gastrointestinal disorders. And the most of the symptoms when your child is having this is they will be having nausea, they will be having diarrhea, there will be a failure to thrive, which means nothing but the poor growth, and there will be a weight loss, and they will be having abdominal and chest pain, reflex that usually does not respond to therapies. So you might have gone to a lot of feeding therapists, but there will be a reflex, there will be a gag coming out. And if your child is not responding to therapists, that means that he is having other comorbid medical condition, which is nothing but eosinophilic gastrointestinal disorders. Okay. And there is something called as food impactions, wherein, food stuck in the throat. There will be certain food stuck in the throat. That is again one more sign and symptom of this. And there is something again, one more symptom is gastroparesis, wherein there is a delayed emptying of stomach, where the muscles are not really functioning well to take away the food from the stomach. So there will be a delayed emptying of stomach. They will be having very poor appetite. You can usually see bloating of the abdomen, and they are usually anemic. And sometimes you might find blood stains in their stool, and usually they are malnourished and they will be having difficulty in sleeping. So these are certain signs and symptoms of eosinophilic gastrointestinal disorders which you need to be ruling out. And the third most important component is again chronic constipation, which most of the parents from where I have seen, maybe around 70 to 80% of the children, especially during 0 to 2 years of their age, there will be definitely a history of chronic constipation. Or foul smelling poop when during especially the 0 to 2 years of period. And all of us know that constipation is nothing but infrequent, hard, painful bowel movements, right? And it is usually again the signs and symptoms of constipation would be abdominal pain and bloated tummy and nausea, vomitings, irritability, behavioral concerns, and poor appetite and refusal to eat. So parents often describe these children as gazers. Gazers is nothing but who eat small amounts of food throughout the day. When they don't sit down to eat a meal, they tend to eat just few bites and complain that they are full. That means they cannot take a complete meal, but they will be taking little meal and little amounts of food all throughout the day. And they, as soon as they take 2 or 3 mouths, they say that they are full. And there are certain food allergies and sensitivities and intolerances which we'll take in the next coming session, because that is again one more important component of children being problem feeders. So I'll concentrate on food allergies, food intolerances, and different kinds of diets in the next possible session. And the other medical component is the side effects of the medications which they are on, because many of the children, I see that they are kept on medication for their aggressive behaviors, for their inattention, for their obsessive thoughts, and for their tantrums and for their hyperactivities. They're kept on different kinds of drugs, and this in itself can cause the side effects of these drugs, especially for those components which I have mentioned. The side effects of this are either decreased or increased appetite, or decreased or increased weight will be there, and they usually present with dry mouth, and there will be an altered taste in their mouth, which makes them not to appreciate different kinds of taste. And they will have severe abdominal pains, and diarrhea and constipation is again one more component. And we all know that our children, most of them are again associated with certain other comorbid medical conditions like, sleep disorders and seizures and allergies and digestive problems, again for which they have been kept on medications. But please remember, whenever your child is on medication, it is always important, which most of the parents don't tend to do, is that you need to have a registered dietitian under your list of consultants, because they play a very vital role in terms of reviewing the potential side effects of these drugs and how to compensate that particular thing. So that is another one area which you need to be really looking into. And then comes the dental causes. And most importantly, because our children do have concerns with hypersensitivity around the gums, and most of you really brushing is again one of the major component which is very challenging for many of you, right? The reason, because they don't allow it, they tend to develop caries. And they will be having sore or swollen gums, or there will be mouth sores, which becomes very difficult for them to really appreciate crunchy, spicy or hot food. So if your child is preferring to eat only the smooth foods or the liquids, please understand that the cause might not be that is a problem feeder or a picky eater. There could be a dental reason behind it. So that's the reason why we usually keep telling all the parents to get your child evaluated by a dentist every 6 months once, to rule out if there is any concerns pertaining to it. So these are certain medical conditions which you need to be really looking at. I'll repeat them. Number one, gastroesophageal reflux disease, eosinophilic gastrointestinal disorders, constipation, medications, and dental concerns. These are the 5 major criterion which you need to be really ruling out prior thinking that your child is a picky eater or a problem feeder. Okay, so that could be one of the reason. Then next comes your nutritional deficiencies. We all know that nutrients play a very vital role in our body, which helps our brain and immune system. And if this is not proper in our kids, if the nutrient supplements are not proper, or if the nutritional diet is not being given to our kid, they play a very vital role in terms of making them become picky eaters or problem feeders, because it does not, if the nutrients are not taken properly, it will affect their brain and immune system, it will affect their gastrointestinal system, and it will affect the detoxification system of the body. And it is very important for all of you to really know the importance of proteins, carbohydrates, fats, vitamins, minerals, and water. These are the 5 major things which needs to be given in right amounts for your child. If they are not given in right amounts, that can cause all these concerns, which can in fact which can in turn make them picky eaters or make them problem feeders. I'll repeat: proteins, carbohydrates, fats, vitamins, minerals, and water. They need to be supplemented in the right quantities for our kids. See, what I have seen in many of the parents, like many of us, when a child is a picky eater, usually in US, the routine typical diet what I have seen for children is like high sugar dry cereals in the morning for the breakfast, and macaroni and cheese for the lunch, and fast food nuggets, and a little bit of soda for the dinner, and a candy as a reinforcer for throughout the day. But what I have observed is, when a child is on that kind of routine diet, where there is nothing else going in apart from that, they are found to be having deficient in their protein, calcium, their fiber, their omega-3 levels, and their fatty acids, and their vitamins and minerals. They are found to be very much deficient on that, which in fact has affected their overall growth or their developmental delay as such. And one more wrong notion what I have seen is, many parents avoid fat and cholesterol, right? But what you need to remember is the carbohydrate. the carbohydrate which we take, the carbs which we take, in turn it converts into glucose, and that is very important for the functioning of the brain, or the brain to function to the optimal level. But most of the parents have seen that they reduce this carb, and what they reduce this carbohydrate, thinking that it is not really good for the child's overall growth. And they limit this fat. But what you need to understand very clearly is, yes, certain fats are very bad, but the unsaturated fats, the mono unsaturated fats or polyunsaturated fats, these are really very important in making of the myelin sheath around the brain. And myelin sheath is something which communicates between both hemispheres of your brain. And if that is not developing the way it should be, then it's going to cause a real concern for your child, because the transmission of information is not taking place in the brain. And usually there is a rapid growth in our kids between 3 to 5 years, 9 to 11 years, and 12 to 14 years. So this is the time where they actually seek for more carbohydrates, and this is the time where actually you need to be giving more carbohydrates. So if anybody would have suggested you to reduce fat and reduce carbohydrate for your kids, please don't do that. It is actually very important for your children to have fat, cholesterol, and carbohydrate rich food. So as I said, these are certain things which you really need to look into. And when you talk about micronutrients, the important micronutrients which play a very vital role are calcium, iron, and some of the vitamin B, a few of the vitamin B things. So calcium, iron, and vitamin B. So why I'm telling you all this is so that you can provide enriched diet for your kids, so that it will aid them in developing the way they should be, and does not become a picky eater or a preferred or a problem feeder. So we all know that calcium is very important for transmission of nerve impulses, and we know that iron produces dopamine, which is very important for mental functioning, right? Very important for mental functioning, or to have a sustained attention span, or to have a good memory. It is also just as I said, your vitamin B, precisely when you talk about vitamin B, in that also it is B1, B2, B6, and B12. They play a very vital role in terms of not creating fatigue for your child, or confusion, or not to have developmental delays, or not to have memory or any neurological changes. So these are certain things. Overall, what happens is, if this particular the protein, the vitamin, the fat, and carbohydrates or micronutrients, if they are not going proper in your kid, that will cause loss of appetite for them. And that this loss of appetite in itself could be one of the reasons for them to be problem feeders, or to be gazers, or to be picky eaters. And it causes a lot of sleep disturbances too. So this is the second component. First one we discussed about medical conditions. And the second one, it is about nutritional deficiencies. And third one is about oromotor dysfunction. Oromotor dysfunction, the reason behind that, what you need to remember here is 70 to 80% of the children on autism are found to be having low muscle tone. And this low muscle tone will cause a lot of issues with their oromotor functioning as such. And whenever a child is presenting with issues with oromotor concern, they have difficulty in sucking, biting, chewing, swallowing, and coordinated lip movements, coordinated jaw movements, and their ability to close the lip in itself will cause a problem. And because of this particular oromotor limitations, they don't prefer to eat food. And the certain symptoms what you need to remember, if your kid is presenting with these symptoms, then you need to understand that it is something to do with their oromotor dysfunctions. One, there will be delayed advance of textures because child cannot chew, and because physically chewing becomes very difficult for them, so they cannot advance from a texture of one type of food to the other type of food, and they have slow and inefficient chewing. Food is often left in the mouth, or food is falling out of the mouth, and they develop gag reflex. They usually cough and choke while eating, and there is delayed advance of other feeding milestones, especially if you are if they are on a sippy cup, to get them transferred to open cup fluid sucking, they will not be able to do that. So their feeding milestones are compromised. So this is one of these are the one few symptoms of really analyzing whether your kid is having any concerns with oromotor dysfunction as such. Then comes the role of the primitive reflexes. There are few reflexes which are very important for a child to develop advanced feeding, or for a child to develop milestones the way it is. So these reflexes which needs to be integrated. If they are not integrated, then child will be having concerns with feeding. And these are rooting reflex, sucking reflex, tongue thrust, transverse tongue reflex, swallowing reflex, bite reflex, gag reflex, fear paralysis reflex, Morose, and tonic labyrinthine reflex. These are the major reflexes which help a child to develop advanced mechanism of feeding. And if these reflexes are not integrated, then child will be having a concern. There is a difference between sensitive gag and swallowing. What you need to understand here is sensitive gag is nothing but before swallowing itself, when food is there in front of them, or when the food is on top of the tongue or middle of the tongue or at the posterior level of the tongue, they gag. But before swallowing, the gag comes before swallowing, and that is called a sensitive gag reflex. And it is very important to rule out that reflex if your child is especially a problem feeder. And as you know, swallowing reflex is nothing but once you swallow, you develop that particular gag. Swallowing gag reflex and sensitive gag reflexes are two different. Once you swallow, you get that gag. But in sensitive gag, it is once it is presented in front of you before swallowing in itself. And the third component, and another component which can affect them, is sensory integration dysfunction. And we all know that eating is one of the complex act, right? And where all the senses are involved, immaterial of anything, all the senses need to integrate together for our ability to finish the act of eating. And each and every sense plays a very vital role. What you need to understand here is you need to rule out if your child is a problem feeder, which is that sense which is actually making it more troublesome for them. Like certain things, I'll just give certain examples. Like if your child is having hypersensitivity to vision, they might prefer food of certain color only. It becomes very difficult when you present food of different colors to them. They might reject, but they might develop a preference to only one different kind of color, and they might not accept food touching in the plate. Food has to be kept separately. They will not like food being touched with each other. And the serving sizes do also sometimes overwhelm them. The amount of food which you keep in the plate, these are all the visual based concerns. These are all visual based concerns pertaining to sensory integration. And the tactile touch, otherwise touch, it is we find the touch at two different levels. One within the oral cavity, and another one with the hand. They become orally defensive, and they will not allow anything to be touched to their cheeks or to their lips or to their tongue. So they avoid food completely because of that oral hypersensitivities or oral defensiveness. And as far as touch is with the hand is concerned, they will not, they might touch only with one finger, or they will not allow anything to be touched. They immediately rub off their hands, or they reject new foods, and they gag and they choke and they vomit once it has been kept forcefully inside their mouth. And smell, when it comes to olfaction, it is the hypersensitivity to smell. They may become more fussy and overwhelmed by the orders of food in itself. While preparing the food in itself, if they're really hypersensitive to smells, they will not come to the table at all, because of that, because they would have already become overwhelmed with that particular thing. And as far as taste is concerned, if they have very strong flavors, if you're producing them, if these all are hypersensitive things which I'm saying, if when you're presenting a strong flavor, that in itself will trigger a gag reflex with them, and may have strong taste preferences or prefer bland foods or specific flavors which they are adapted to. So that is something which needs to go with the taste. And auditory, if they are hypersensitive, what you need to understand is this is very important component which you like. Certain children, for the sake of auditory hyposensitivity, to provide to make themselves calm, they eat spicy and crunchy food all the time, and they get adapted because of that sound which they want. Or they don't eat food, this crunchy food, they don't take it because that sound itself they cannot tolerate. So it could be because of their auditory thing. So most of the time when a child is hypersensitive to sounds, they often prefer soft food and liquids. If you're giving your child that mashed food, or if you're giving your child the soft foods or the liquids, and if he's tolerating only that, it could be something to do with the auditory component, not actually something to do with the feeding as such, or eating as a behavior as such. Okay, so and the proprioceptive capability of the temporomandibular joint. They really don't understand how much mouth needs to be open to take each, to keep all the fingers inside the mouth, or to take a spoon inside the mouth, or to drink from a cup. They will not be really able to understand that dynamics of how much the mouth opening and closure is required. So so as I said, every sense plays a very vital role in our ability to finish an act of eating. And imagine one of this is not being in place, automatically they become problem feeders. So it is important to evaluate the sensory integration and how all the senses are getting integrated in your child to finish that act of eating. Now, if your child is hyposensitive to this sensory things, they may seem obvious during mealtime. They have trouble differentiating between textures, tastes, temperature, and smells, and they really doesn't know whether they are full or they can eat some more. Which in other words we call it as portion control issues. Like some parents complain that my child keeps on eating, we don't know that he doesn't know that or we don't understand that whether he's full or he's hungry, or whether his appetite is so big or appetite is lost. So these concerns come up when your child is having sensory hyposensitivities. When, as I said, they will have problems in textures, they will have problem in taste, in their smell, in temperatures, and the amount of portion which they need to take. So all these are related to the hyposensitivity concerns and the sensory integration processing concerns. Now, when you really look at the other side of the component, the environmental factors, they also play a very vital role in getting your child to become a problem feeder. And major environmental factors, if I have to list down for you, are distractions or grazing, lack of routine, and having a mealtime dynamics, the disturbed mealtime dynamics, and improper physical environment in the home. All these factors will add upon for them to become a problem feeder. And behavioral concerns, which we usually, once you really rule out all these areas, like once you rule out the medical conditions, once you rule out the nutritional deficiencies, and then ruling out whether your child is having oromotor dysfunction, or whether your child is having retained primitive reflexes, or whether your child is having sensory concerns and the environmental factors. Once you rule out these 6 categories, then you need to actually look at it as a behavioral perspective. From behavioral perspective, where the negative mealtime behaviors, it's otherwise called as negative mealtime behaviors, where there is a refusal to come to the table, or they are not sitting still in their chair, or they are refusing to eat, or crying when presented with food, or they're throwing tantrums, or gagging or vomiting during the mealtime, or spitting out the food, or disrupting others while the food. These are other components which are classified as problem feeders from the behavioral perspective or from the ABS perspective. So these are certain things which you need to really look into before actually working with your child. So I'll repeat it again. To concise everything, I'll repeat all these things again. Medical conditions such as GERD or EGID or constipation, That is number one. Number two, medications. Number three, oromotor dysfunction, whether your child is developing a proper oromotor developmental milestones. And number three, the sensory concerns, whether it is hypersensitive or hyposensitive, that has to be ruled out. And number four, the effect of medication. Number five, about the environmental factors. So these are the, and number six is your behavioral categories. So these are the things which you need to actually pen it down, which you need to maintain a diary for 3 days in these particular areas to actually see where exactly the problem is. Once you identify the problem, then how to actually handle that problem becomes pretty much easy, right? So as I said, these are the categories. These are the categories where you need to be really looking at if you are really want to make your child overcome this particular concerns with feeding. And believe me, most of the kids whom we have worked, they have overcome this within 7 to 8 days, or within a week to a fortnight. You know, it doesn't take beyond that when you identify the problem and address the problem the way it is. And there is something called as I guess probably most of you know that there is something called as eating hierarchy. I'll explain you about that. And the way you manage these things, after you identify, the way you manage these things, number one, if there is an oromotor dysfunction, then it is to do with roots approach, where we try to do massages on the oral oroperipheral areas to increase the awareness of the oral structures and to make sure that child understands each and every part of the mouth and the sequential pattern of eating, the placement of the tongue and the placement of the lips and placement of the jaw. All these are taught if the child is having oromotor dysfunctions. Then if we find that there are certain retained reflexes in your children, then reflex integration therapy is the one which needs to be carried out. And then if there are any oral defensiveness, if there are any sensitivities, whether hypersensitivity or hyposensitivity, it has to be dealt by sensory integration therapy. And as I said, it is a combination of people working. So this oromotor dysfunction and these oral sensitivities are the part which can be taken care, and reflex integration. These are the parts which can be taken care by your occupational therapist. And there is something called as where your speech language pathologists will work. They call it as food chaining and sequential oral sensory therapy. SOS, probably most of you would have been, those who are going for feeding therapy as such, might be knowing about this SOS. SOS is nothing but it has been classified at 6 different steps. Number one, they call it as tolerates. Number two is about interacts with. Number three, smells. Number four, touch. Number five, taste. Number six, eating. So it is classified into these 6 categories, where there are 32 steps involved in each in completion of this act of eating. So tolerates is nothing but they evaluate whether being in the same room or being at the table with the food on the other side of the table, and being at the table when the food is halfway across the table, and being at the table with the food outside of child space, and looks at food when directly in child space. So this is the process how they usually work in getting them to tolerate with the food. And then they teach them how to interact with the food, and then they work on these orders, smells. They work on this order in the room, the order at the table, and order in child's forward space, and then leaning down and smelling it. So every process of this, every step of this, SOS therapy has got its own steps involved in it. As I said, it has got 32 steps, so they go sequentially in that. Those, as the word says, sequential oral sensory therapy. So these 32 steps are taught, or these 32 steps are introduced child one at a time. Like when you talk about touch, in that they say that first with one finger, with the tip of the finger, then all the fingertips, then the finger pads. So it goes in that order, where they systematically desensitize a child towards overcoming this problem feeding completely. So these are certain things. What food chaining is nothing but the sequential, again, chaining is nothing but again a sequential introduction of food along with their favorite food. What they say is your child may find these foods acceptable because of their color or their texture or their flavor or even their visual appearance itself. So they try to figure out that first, and food chaining determines why your child accepts certain food, and this shows how to expand his food repertoire by introducing different food with the same features first, and then changing the kind of features. So they first identify what is that, and then introduce different food of the same texture or the same smell or same flavor, and then slowly introduce them with the other different foods they keep adding on. So that is called as a technique called as chaining. So chaining and sequential oral sensory therapy is something which is done by speech language pathologist as a feeding therapy program. And as far as ABA is concerned, they work on these behaviors which we have spoken by either adding a reinforcement or by the reward systems, the token economies, the positive or the negative reinforces. All these things are certain things which they usually use, the ABA therapists usually use. And there are certain at-home strategies which we call, which is nothing but what parents can actually use. They can you can use reinforcements as designed or told by your ABA therapist at home when you are trying to feed your child. And there is something called as social modeling. Whether your child eats or doesn't eat, you will make sure that your child is sitting along with you at the table while mealtime, and other siblings at home, or doing a modeling in a way. A positive modeling is happening in front of the child, like there are no negative faces or no negative talk about the food when the child is there in front of you, whether he's eating or not eating. That is called as social modeling. And most of the times I find a lot of parents keep kids on unlimited juices. They give 10 cups or 12 cups of a juice every day and forget to give water. But if you're doing it, limit their juices at home, and don't let them graze throughout the day. Like, don't let them allow to eat small quantities of food throughout the day. Don't make them become grazers. And stick to a schedule, create a routine, mealtime routine, and limit all the distractions during mealtime, especially if you're keeping televisions, or if you're keeping mobile phones, or if you're discussing across the table while eating. All these things can distract your child. So limit all the distractions whatever is possible, and offer manageable foods. Like, don't overload the plate with whatever you cook, and make it look very messy for the child. So offer manageable foods for them to eat, and use appropriate mealtime language, which is very important, wherein there should not be, what we say is, there should not be any negative or no kind of word being used at the dining table or during the meal time. And avoid burnout of food. Like, don't always provide the same kind of food or prepare the same kind of food for the child. So avoid the burnout of food. And these are certain strategies which you can really work upon at home. And there are certain tests which are usually prescribed, blood workup and stool workup. Usually what they do is, first you need to really look for food intolerance tests for your kids, and you need to look for thyroid panel, because hypothyroidism is found to cause constipation in kids, and hyperthyroidism is found to cause diarrhea in them. And get a comprehensive metabolic panel, which is very, very important to find out how proteins, vitamins, minerals, and carbs are are in your kid. And celiac disease panel is again one more panel which they usually do that. And they evaluate for lead levels in the blood, because again it is related to constipation, and that becomes them to become a problem feeder. And serum carnitine is again one of the major component which is found to be deficient, or again one more component which is important for synthesis in the body. which tells you about how the fatty acid absorption is taking place. So that is again important, and that's called serum carnitine. And they do IgE levels to figure out the immune system or the allergy levels of kid. And stool analysis is again to rule out other possible concerns pertaining to constipation or pertaining to the overall health of the gut. These are certain tests, and usually your speech language pathologists sometimes they ask for barium study tests on to figure out how the swallowing is taking place, and certain pediatricians will ask for endoscopy and all those things. So as why I'm saying all this is, it is important prior to labeling a child as a problem feeder or a picky eater to rule out the organic causes. First, to rule out the organic causes, and then it becomes easy for you to classify them, or to see what are the combination of all this, like the medical, sensory, oromotor dysfunction, and or nutritional deficiency. So the combination of it, you can easily work them together to make the child overcome the concerns. So I hope it was helpful for you. So in the next sessions, probably we'll go into some more details of food intolerance and food allergies, and the GFCF diet or Nemichek diet or elimination diets. All that we'll discuss in the next possible session. So Saujanya, I'm done for today. So if any
Thank you so
questions?
much. It was very quite a useful information. And would you like to take 5 questions, sir?
Sure, Andy.
Sir. Any parent has a question, kindly pose your question and try to be very specific in the interest of time. Anyone?
Yes, Saujanya. My name is Srinivas.
Go ahead.
My kid is not eating only fruits. Fruits alone she won't eat. So she like to eat other things.
Go ahead.
Yes, sir. So she's having like a fear with like to see new people. She's having fear, but coming to the food, she won't eat fruits and coconut milk. So sorry, coconut water. So she will smell and she won't drink.
So that's as simple as that. So you need to be really working upon her olfaction. Maybe she is having too much hypersensitivity with the smell.
Okay.
You need to probably work upon her oral defensiveness for certain textures inside the oral cavity.
Okay, okay, sir. So is there any test I have to take?
No, see, if there is, see, what you need to really understand here is in the fruits also, there are certain fruits which are citric, right? And if the child is having esophageal reflux, or if the child is having a lot of eosinophils in one of the area, so that they can cause more irritability. So it is important to rule out the gastrointestinal concerns first, and then and rule out the food intolerance too. Just get food intolerance test also to see what are the fruits which a body can absorb and take, and what are the foods she is intolerant to or allergic to. So if you can rule that out, then you can think about in terms of sensory processing concern, and keep before going to those getting those tests done, try to provide her with the different smells of fruits first. Not fruit as such, just the smell of the fruits. Which
sure.
should be there in the candles or in different forms. Just get her adapted to that first, and then slowly introduce the fruits and see. And alongside, check whether she's having any oral defensiveness for certain textures, and try to work on that. So I think that should solve the problem for the baby.
Yeah, sure. Thank you, sir.
You're welcome.
Thank you so much, sir. Can we take up the next question, please? Anyone? Please unmute. Please unmute and ask your question.
Hello, sir. Good evening. Actually, my son doesn't like to drink any juice. He can eat fruits and all, but he doesn't like to drink juices.
Gag when you present him with the thickness of juices. gag, or does he spit it out, or does he vomit when you present him with juices?
He doesn't want to, means he will throw it away. He doesn't even don't taste.
About drinking water.
Yeah, only drinking water.
He drinks water?
Yeah.
So it might be more to do with the taste, and it might be more to do with the taste of the juices. So ask your therapist to work on the gustatory levels, because when you're working on the gustatory sense as such, there is a different pattern to work with it, because of the what do you say, the taste buds, because of the taste buds located at different places on the tongue, the way they need to be working, there is a different protocol for that. So you need to ask your therapist to really give you a program to work on the gustatory hyposensitivity.
Okay, sir.
Yeah.
Okay, thank you so much.
You're welcome.
Parent.
Yeah. I think Saujanya will wind it up.
Okay, sir. Samraj, sir.
Yes,
Thank
ma'am.
you so much for taking this topic and collaborating with me for so many wonderful topics that we have taken so far. And you have majorly contributed in providing knowledge to so many parents here on MITRA Group. And thank you, sir. Thank you so much for your contribution. And I really enjoy doing these webinars with you.
So much for that, ma'am. Thank you so much.